The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, or good morning, depending on where you're at. We're very excited to be able to present the seminar today on Summer of Our Discontent, COVID-19 Still Rages. We are so fortunate to have two experts tell us what the latest is in COVID-19 and kind of dispel a lot of the misinformation that's out there. So we have today Dr. Joe McCormick and Dr. Susan Fisher-Hawk, and they are both professors of epidemiology at our Brownsville campus for the UT Health School of Public Health. I am Deanna Helscher, and I am the director of the Michael and Susan Dell Center for Healthy Living at the UT Health School of Public Health in Austin, and we are sponsoring this seminar today. Our mission is healthy children in a healthy world, and with the school reopenings, you can certainly see why we need to know about COVID-19 and what's happening there. So before we get started, I just wanted to cover a few housekeeping announcements. One is that this webinar is being recorded and it's going to be archived along with the presentation at our website at msdcenter.org. So we will give you that website again, and if you're on the webinar, you will get that information. All attendees will receive a certificate of completion this afternoon. So if you don't get it, please let us know. CHESS credits are available for this webinar, and if you email dellhealthyliving@uth.tmc.edu, we will coordinate that. And I'll put it in the chat box so that you can see the email address. And finally, if you have any questions during the presentation, please enter them into your questions chat box. We will have time for a question and answer at the end, and we'll also try and follow up and answer any of those questions that we can. So once again, I'd like to thank Drs. McCormick and Fisher-Hawk for making time to enlighten us on what's happening in the COVID-19 world these days. So I'll turn it over to y'all.
Thank you very much, Deanna. It's our pleasure to be able to talk to you about what we've learned since the last seminar. This is an epidemic that is like a freight train moving through our population, and our knowledge is increasing every day. New things are being learned, everything from prevention to treatment to what's happening in various parts of the world. We have quite a few slides here. We're not going to be covering every single thing. We're going to make just comments, but the slides will be there for you to come back to if you are interested in some particular area. We try to include as much information on those as we can. So with that said, we'll get started. And I think Kate, could we have the next slide?
So I'm just going to take you through a little background. Next slide, please. We could call this a plague as well as an epidemic, and they've been recorded over the history of humanity for at least 5 millennia. This mass grave China 3000 BC is the first documentation we have, and you see the Renaissance type depiction of the devastation of a plague in the picture. Next slide. So I just made this list. I'm not going to go through it. It's here for you to look at later and to Google anything you find interesting. But if you look in the third column, the number of deaths, they have been enormous. Sometimes at one stage, 15 million, 30% of the population, half of Europe's population. So this is not new. And the underlying features have always been population explosions and crowding and increased transport, that is movement of people. And I think we're seeing a lot of that now. Next one. So this is a very interesting graph, the conquest of pestilence in New York City. I like it very much. And it's a graph of death rates. And as you can see above these spikes, there will be events that occur. There's cholera, there's plague, there's dysentery, all sorts of things. And you come down to 1918, the great influenza pandemic, where New York had 12,562 deaths, we find. After that, interestingly, it kind of goes flat. And this was the period, particularly after the Second World War, when we all rubbed our hands with glee and said, that's it, infectious diseases have been conquered. We have no problems anymore. And I think you'll see that we are just about to get another whopping spike on this graph, if they care to update it. Next slide. And the next slide. And the next slide. I hardly needed to comment on those two slides. And so the next slide is, what is a coronavirus? This is the animal we're dealing with right now. It's been given a strange name of SARS-CoV-2, and that is the name of the virus. And it is short for severe acute respiratory syndrome coronavirus 2, to distinguish it from the SARS coronavirus 1 that occurred about 10 years ago. The disease, however, is called COVID. That's coronavirus infectious disease 19, from the fact that it was first observed in 2019. So that if there's any confusion, you can come back to that and figure it out. So next one, please. So there are millions, billions, or more likely trillions of viruses in the environment. And our problem is that we're invading this environment. And as we do, we come into contact with viruses we haven't met before. So right now, and this is probably a minimum, probably tip of the iceberg, at least 36 known animal coronaviruses. We actually have 4 human coronaviruses we know quite a lot about. They cause a third of all common colds. They're winter viruses, and unfortunately, the immunity to these viruses lasts less than a year. So if our virus A gets you this year, virus A can get you next year too. Then this is a little bit of a worry about long-term immunity. SARS-CoV-2, however, infects both upper and lower airways. So it's not a common cold, it's more of a pneumonia. And it has a special way of getting in, which is pretty lethal. Its spikes attached to an ACE2 receptor. Never mind the name, it's a common receptor found throughout the body and in the lung. So it's on lots and lots of your cells, and the virus attaches to it. And then it's cleaved by a very, very common enzyme, which again is in all your cells, which allows it to break apart the spike and get into the cell. Next slide. I'm going to hand over to Dr. McCormick.
So on the right-hand side, the cartoon shows you what happens in all of us when we translate our DNA into proteins that make up our cells. And we go from DNA to mRNA to pre-mRNA to mRNA, that's messenger RNA, and then on to a message that attaches to a ribosome that makes the protein. It turns out that there are viruses that mimic every step of what we do as humans, and many of these viruses are familiar to you. There are DNA viruses that start as DNA and have to get translated once they get into cells into protein, just like you see on the right-hand side. Those are herpes, smallpox, adenoviruses, chickenpox. And then there are viruses that are in that intermediate strand. They're called negative strand viruses. And they are familiar as well: HIV, polio, flu, Ebola, measles, mumps. And then there are so-called positive strands that are at the bottom of that cartoon, and they can attach direct, when they get into the cell, they don't have to go through all that other step. They just attach to the ribosome, take over the ribosomes in the cell, and start making their own protein. And there are a number of those, including dengue virus, they experienced with, and this SARS-CoV-2 virus is in that group. So that gives you an illustration of how viruses mimic what happens to us and why they can go into cells and take over the mechanism in cells and make copies of themselves. Next slide. So as Dr. Fischer-Hawk said, You can see where the ACE2 receptor is there. That's a cartoon of the RNA of the SARS-CoV-2 virus. It attaches to that receptor. It goes in and starts to connects its RNA to the ribosome and starts to make its own proteins. They get assembled in the cell, and they come back out as a whole virus, and that's exactly the way this virus operates. Next slide.
So as you can see, it's a method for hijacking the cell. But the real problem with coronaviruses is they are very labile, and they can species jump. And when they do this, they can get very unexpected results. And classically, the original host is well adapted and doesn't get sick and carries the virus around. And if it's a bat or a camel or some other animal, you don't even know it's sick. But when it gets into humans and sometimes primates, it makes it very, very sick. It makes you very, very sick indeed, or at least it can. Next slide. So I'm going to tell you about the disease first of all. Next slide. So this has turned out to be a very protean disease, and it has given us so many surprises. We had this slide before, and it was at least half the size, probably less. And we've had to add all these signs and symptoms. So mild disease is quite common. We do not know what the rates are, but people are talking about 50 to 80%, maybe less, we don't know. Certainly a lot of asymptomatic infections in young people and children. Body aches, headache, tightness of chest, dry cough, short of breath, loss of taste and smell, and fatigue. These are all the kind of descriptions that people that we know, and you probably know as well, who are likely, who have had symptomatic COVID-19, and they tell you it's very unpleasant. There is, more uncommonly, a long COVID disease where it persists for weeks and sometimes months. And that is also quite a problem. The severe disease, however, is a totally different animal. And it can be very biphasic. People can seem to get better and then suddenly go down very bad. And they get widespread viral pneumonitis, a lot of destruction in the lung. And this results in the so-called acute respiratory distress syndrome, where there's very, very severe shortness of breath, and the patient requires oxygen support and often ventilation. But there's also a cytokine storm, and the distinction between the direct attack of the virus and the immune system's response is still very hazy. Both are important, and they cause different levels of injury at different times in the disease. So the outcome can be cardiac injury, heart failure, kidney failure, multi-system failure, and there is an extremely interesting phenomenon of abnormal bleeding and clotting, and some anti-clotting treatments been used. Mortality can be very high. Mortality clearly depends on the quality of care that you get in the hospital, because the bottom line is very good hospital ICU care is probably the best approach right now. Next slide.
Okay, so in addition to the clinical diagnosis, that is based on the symptoms that you just saw, and probably some new ones that we'll learn about, we also have to worry about the laboratory diagnosis. That is, how do we decide who actually is infected with the virus? And so these targets are marked here with the arrows. And when a swab is taken of your nasal pharynx or the back of your throat, it picks up the RNA, either the whole virus or the loose RNA that has leaked out of some of the cells in your nose or throat. And now a new test has come along that is a saliva test, and it essentially picks up the same thing, except the virus and the loose go to the laboratory, where we make the essential part of a PCR test is, and what makes it more sensitive is that the process actually copies the viral RNA that we talked about earlier and makes many DNA copies. We talk about a thermocycler, which means that it goes through 30 or 40 cycles of making these copies, And that increases the sensitivity of the test. So you have a lot of DNA copies, and eventually you can detect the presence of the virus. And that's the principle of the PCR test and how we get the material for it. The swab sample, it can also be used for what's called an antigen rapid test. And that is one that where it contains the virus and the protein part of the virus. And then we make antibodies to, the antibodies are available to these proteins, and you can detect the proteins. It's less sensitive, but it's very rapid. And then finally, there is a blood test for antibodies that eventually are made against the proteins. It's not a test for infection, but it's a test that shows whether you have been infected. Next slide. So I've already described to you how the PCR works, but it makes copies, as you see, and detects the virus. And you remember that the test is only, for the virus, is only valid the day it's taken. You could get infected the next day and then be positive. And the result can also be a false negative, in the sense that for many reasons that there wasn't a lot of virus there, or there was a problem with taking the specimen, or something happened to the lab. Any one of those can give you a false negative test. That is, it's negative, but you actually are infected with a virus. Sometimes the false negative means a low amount of virus, and maybe or maybe not, you may be infectious for other people. The antigen test detects a viral protein, but remember, it's only detecting what's there. It doesn't amplify like the PCR, and so it's far less sensitive than the PCR because we can't copy it. Next slide. The antibody test is for immunoglobulin, as it's called, and that is increasing. There are more and more of these tests available. That uses a blood sample, obviously, to measure the blood antibody in the blood. Here you can get a false positive as well as a false negative. And again, this does not diagnose acute disease. It only indicates that you have been infected sometime, maybe recently or some other time in the past. Next slide. These are all the reasons why you might get a false negative PCR or antigen test that I've already described. This is for you to refer back to if you want more detailed information. There are a lot of reasons, as I've mentioned, why you might get a false negative test. Next slide.
So we're going to go to transmission now. Next slide. So recently it's become apparent, and there's been some good experimentation, that coronavirus is in the air. It is spread by aerosol. And WHO has finally agreed. Aerosols are very small particles. They float in the air, and they can travel for several meters and hang around for hours. And this is really worrying. And this is why we're having to take such steps as social distancing, as masks. The consensus, though there is some argument, is that large droplets and small aerosol particles contain the virus. However, the aerosolized particles can hang around in the air a lot longer, and you can inhale them. You can go into a room where somebody who has exhaled virus, and you can be infected from it. So this is worrying. And these particles come deep in the lungs of infected people. And the closer you are to the patient, the more likely you are to get an infectious dose. You know what it's like if you don't smoke and you pass by somebody smoking and you get this sort of horrible smell quite a long way away from them. That has come from inside their lungs. And so the same thing is really happening here. Now, if someone's talking, coughing, laughing, or singing, or sneezing, these aerosols travel even further. Next slide. Next slide. So there are some aerosol data. It's pretty good. I'm going to go through this, but it's there for you to look at if you are interested. Next slide. So I just touched on that slide of the Darwin princess, and it's now becoming more apparent, as it was to us in the first place, that the infection must have been spreading through the air ducts because everyone's confined to their cabin. And I'm just going to show you two events that really illustrate this. This was the super expensive high-end birthday party in an upscale suburb of Westport, Connecticut. And it did not have a single known case of the coronavirus the day of the party. It had 85 10 days later, up more than 40. The party goers, half of whom became infected, left that evening for Johannesburg, New York City, wherever. So the potency of party spread is really very powerful. Next slide. And this is a paper from China, which is very interesting. On the left, you will see 5 dining tables with the diners laid out. Diner A1 on table A was infected the day that they had this, I think it was the New Year's lunch kind of thing. And you will see that diners A3, A5, A2, and A4 all became affected. But worse, 3 people on table B and 2 people on table C became infected. On the side, you can see there's some arrows. That's where the air was blowing in the air conditioning system. And the little inset below, you see the blue area at the top with the little arrows. That's where those tables were. And that's where the infection spread. But the green tables, there were no infections. So it's not a question just of poor ventilation or what kind of ventilation you've got that allows the virus to spread in an enclosed space. And this is why indoor dining is such a high risk. Next slide.
So we're looking here at a more local data to show you what happened in Cameron County, which is where our campus is in Brownsville. And you can see that, though you can't see these dates, you can just see the dramatic increase. We were in pretty good shape with about 10 to 12 cases per day during the shelter in place early on, as the vertical lines show you. And then as phase 1, phase 2 of reopening and phase 3 occurred, and particularly phase 3 just after, during and after Memorial Day, you can see the massive increase in what happened in Cameron County. Next slide. Now, what accounted for this? So we looked at the change in age groups, and the blue shows you age group 15 to 40. And you can see that early on in April and May, those numbers were down below 30%. During the surge, the so-called surge, they were up to about 60%. So that represented a group that really seemed to be fueling the transmission. Next slide. And so the question is, what was happening that made that group particularly prone to be transmitting the virus? And what you can see here with the blue represents what we call community spread. That is, people didn't know where they got it, as opposed to the pink or the brown, which is a link to a previous case, and the tiny little gray at the top, which is travel. What this shows you is that we saw a massive increase in, quote, community spread. That is, spread was going on and we didn't know where it was occurring. Next slide. Finally, we looked at the proportion of the community spread, and you can see here that the overwhelming amount of community spread, once again in blue, is in the age group of 18 to 29, 30 to 39, and 40 to 49. So that told us that, in fact, younger adults were going out into restaurants and elsewhere during the reopening, and that's fueling the spread. Could we get the next slide? There we go. Now what you can see here is you see that the age group 35 to 64, 18 to 34 in green, you saw where it was very small, it surged, This is a weekly number. And now you can see with the new guidelines, it's just starting to decrease again. So we hope that this is that this shows us that we can in fact control this, and that when we do, as things get better, they're not perfect by any means, but the number of infections in this younger age group of adults has started to drop off again. Next slide. And this just shows you the number of related deaths that occur during this massive period of reopening and the surge that we had. And it cost an awful lot of lives when that decision was made. Next slide. This is interesting because it is a measure of people's movement using cell phone data that shows movement within the community. And you see that big dip in the middle of this blue graph. That shows you the drop off in people's movement based on cell phone during the shelter in place. And you see the vertical lines show you what happened when we had the reopening, and it shot right back up to, and that correlates quite well with the red line you see there, which is the number of new cases. So reopening the economy resulted in not only the massive increase, but also increase in people's movement, which means they were going out and spreading the virus again in the community. Next slide.
Next slide.
Okay, so now you can see how huge this has become. There are actually, this slide's already out of date, and it was early August, because we're up to something like 23 million cases now in the world, and the US is still occupies about 25% of those cases, about 5.5 million, and about 22% of the deaths, because we're up now to 175,000 deaths. So the US, with 4% of the global population, is contributing 25% of all the reported cases and 22% of the deaths. Next slide. And if you want to know how adequate the response has been in terms of controlling the epidemic, I think it's quite instructive to look at these two graphs. The blue you see at the top there is the United States, and you see, and you know that it's continued to go up. This is just the end of June and early July. It's continued to go up, whereas the European Union, with another more than 100 million more population, remains quite low. And that's because they had serious lockdowns, and they kept them until the number of cases dropped to a manageable amount, and they've managed to keep that. They are seeing a little bit of uptick in some countries. France has gone into another semi-lockdown, but in places like Italy and Spain, so far things are being maintained pretty well. Next slide. This again just shows you the massive increase in cases in the US, and even China, where the thing started. Look at where they are: Japan, China, Italy. Russia is having a problem, and of course Brazil is starting to compete with the United States with a massive epidemic. But once again, a poorly responded, the government has responded poorly, as our federal government. Next slide. In fact, this is our weekly rate, and Brazil has surpassed now the US in terms of weekly cases, though the US is managing to still get around 50,000 cases per day. This is number of cases per 1 million residents, but we're still seeing between 50 and 60,000 cases per day in the US. Brazil is even surpassing that. Next slide. Next, yeah. Go ahead.
So we're going to get into schools in a minute. The countries that had the virus under control are now getting a comeback. We're very concerned about the fall when influenza joins in the fun here. We're not quite sure what will happen, but I think that, well, if somebody gets flu and then they get COVID or the other way around, they're likely to be particularly sick. Next slide. Now, this I do want to show you because excess deaths. You saw the New York map of the epidemics over the couple of centuries, and they did this by measuring deaths. And this is done every year by the CDC. The excess deaths in January and February are attributed to influenza. And so many people have tried to say that the reason for increasing cases is the increase from expanded testing, but this is in fact not the case. And you can see for the USA on the left that the actual increases in cases has massively exceeded the increase in Texas. And you can see here in Texas that if it were a country, it would have the 6th highest cases in the world. So that's not a good place to be. Next slide. Now, this slide is quite interesting. Again, excess deaths, and for the South, West, Midwest, and Northeast. And you can see the distribution in time, particularly the Northeast having the earlier ones, the South having the later ones, and you can actually see it by state. And I'll leave you to look at that later if you wish on the right. Next slide.
So here we see just the number of deaths per 100,000 population in selected countries. These are ranked, and interesting, Belgium has the highest deaths per 100,000, all the way down to Mexico and down below. The US is kind of in the middle of the pack there in terms of number of deaths per 100,000. But it still is, it's now become in the United States the 3rd most common cause of death. Next slide.
Schools. I'll leave this to you.
So should the schools reopen and when? Is it obviously a major question right now? And we're seeing the consequences of many universities that have tried to reopen. And now we know there are literally thousands of students who are already under quarantine, and a number of the universities have had, major ones in fact, have had to return to online learning and to close their campuses and their classrooms. Next slide. And this is just an illustration here of some experience with, if you will, with students and trainees in various circumstances of education. This is from the MMWR. There was a large outbreak among 597 Georgia residents that attended a camp. There was, as you can see here, the number of positives. The median age of that was 12, and you can see that the attack rates were anywhere from 51% in the youngest up to 29% in the oldest, which mainly were the counselors in the camp. But everybody got infected. Every age group, I should say, got infected. Eventually 260 out of the 344 tests were in fact positive. Next slide. Go ahead.
So this shows what happened in Israel as a cautionary tale. And they decided in early May to reopen their schools because they decided they'd have made a good job of getting it under control. And it's estimated that closing schools when the cumulative incidence was in fact pretty low. There were very few deaths, and then this exploded into an epidemic. So children are able to really fuel a further spike in this is why we are so concerned. Next
let me just comment that that's also true for influenza. In the past with influenza, people thought, oh, we don't need to vaccinate kids, we need to vaccinate, particularly Baylor University. Opening the schools in the fall played in transmission of flu, and that's why the recommendations are made now for all school children to get, particularly younger ones, to get flu vaccine.
Next slide. I don't think we're going to go through this except to say to you that detect and contact tracing is a very, very sticky subject. If you have an enormous number of cases, contact tracing is no longer possible. If you have a system like they had in South Korea, where they were very, very strict and they used people's individual personalized cell phones to track their movements and infections, and their quarantine was correctly, completely enforced, then you can control the disease. The interesting thing is that this particular approach was used by the Venetians in the 16th century to finally get rid of the plague. And we haven't invented anything new yet, except for the cell phone.
One thing to comment about this is that the highest, this one study that we had to look at transmission to various age groups and families showed, in fact, that the highest rate, almost 19%, was contacts of school-age children. So this was one of the earliest indications that indeed children do transmit this virus, even though they don't get as ill or ill as frequently as others. Nevertheless, they are infected and can transmit it.
Next slide. So treatment of, quickly, next slide. So I'm just going to go through the treatment where there have been studies which are well developed. Dexamethasone is a well-established drug, and it dampens the reactive immune response to the virus. And this definitely reduces 28-day mortality. But there's an important rider here. It has to be given late in the disease, not early in the disease. If you treat a viral infection with something that depresses the immune response early, the virus has a good chance to take off. But later on, in many of these severe virus diseases, the immune response is actually what's causing the symptoms. At that point, dexamethasone is very effective. Next slide. So these graphs on the left show you that several groups of patients, in A, B, C, and D. A was all participants, and this is mortality at 28 days. Group B had invasive mechanical ventilation. That meant that they had were ventilated. You can see the success rate is even greater there. Group C only had oxygen, and Group D, no oxygen. So Group B shows you that the more severe the patient is, and if they're on ventilators, then dexamethasone is very effective, and that's where it should be focused. Next slide. Then there's remdesivir, which is an antiviral, and in theory, it should be given early in disease, but it's an infusion, an IV infusion, so it's not really being used like that, and that's giving us some problems. It does reduce lung virus levels and lung damage, and it is active against SARS-CoV-2. So the study is a big study, and it's pretty conclusive. It's got good results in terms of relative risk. This is the basis on which we're using remdesivir. Next slide. And here's a similar graph. The red lines show the people who had placebo, and the blue lines, the ones that have remdesivir. And these are estimates of cumulative recovery. And the conclusions, if you look at these, is that it is very important in patients requiring oxygen, but the treatment with antiviral alone is not sufficient. So it's good. It may not be used correctly, because perhaps what we need to do is give it on the first days of treatment. And we've had considered illness on the first day of illness. We've had experience with other viruses that have high mortality rates, and we find exactly the same thing. Next slide.
So this is the convalescent plasma story. And there was an enormous non-randomized trial that was conducted primarily from Mayo Clinic, but many hospitals involved across the country. And the data, unfortunately, because of the design of the trial, i.e. no controls, no untreated controls, and no measure of antibody levels. They just collected plasma from people who were, quote, recovered. but no way to measure what the antibody levels were, the type of antibody. They found that those who received transfusion within 3 days of diagnosis had a 7-day death rate of 8.7%, and those who received plasma 4 or more days later, 11.9%. This is very weak data, and nobody can understand who really responded properly or not. And indeed, 2 days ago, the FDA has suspended the current treatment with convalescent plasma because of inadequate data, and now they're going to do some proper controlled trials with plasma where we measure the antibody and we know something about it. And that way they'll learn actually how it works. So, currently all treatment with plasma has been stopped by the FDA.
In fact, just a rider here, we don't know of any viral illness that has been effectively treated with plasma in this way. When it has been, when they have been treated, hepatitis B with the concentrated immune globulin of known titer does seem to work. However, this kind of treatment, there is nothing in the literature that shows that it works. Next slide. Prevention. Next slide. A quick note on herd immunity is it is a little bit of a fantasy. It is estimated we need 70% of the population to be infected to get herd immunity. Current estimates that around about 10% have been infected, and the 10% have led to 170,000 deaths. So if you want to go from 10% to 70%, you've got to multiply that by 7. So if you just do that simple math, you'll see
that we'd have about 1.5 million deaths.
1.5 million deaths. So it's not a rational approach. Next slide. Prevention and spread. You know all these things. I'm not going to go over it, but certainly ventilation is fundamental. Wearing a mask and keeping your distance. Next slide. Masks. Masks are really, really work. The slide I like most, the picture I like most of all is the little girl on the right. If you can't read that, it says, if you're reading this, you're too close. And if I find that mask, I think I'd get one. But it can be a fashion statement, and interestingly, some of the fashion houses like Balenciaga, you can buy $50 masks if you wish, if you like to be really classy, or you can turn it into a joke. Anyway, so treat masks as a fun experience in terms of how you dress yourself. And you know, you can color coordinate and all those things. Next slide. However, here are some really interesting data on masks. Green is no masks, red bandanas, orange lines are cotton, blue are surgical. If you look at the graph on the left, you will see that the best protection is those with the very lowest little dots down there. The very best is the N95. Surgical are good, and cotton masks are very good. And the best of the cotton masks are 2 or 3 layers of cotton. However, when you get to bandanas and knitted masks, they're no better than wearing no mask at all. So the type of mask you use is really very important. So for general public use, we would recommend that you go for cotton masks with 2 or preferably 3 layers or even pleated masks. So choose your mask carefully and with style. Next slide. Next slide. And here, in case you haven't figured out how big 6 feet is, there are a few illustrations I got from the CNN, which I thought were rather nice. So you can figure out how far apart you need to be, but that also works. And you see from the aerosol data we discussed earlier, why it works. Next slide. So resistance to wearing to public health interventions, interesting, also has a long history. In the 19th century cholera outbreak, libertarians battled every step, fought sewers and water mains being dug through their properties. And they argued they go on perfectly good wells and cesspools. So what did you want public? Why did you want public water and public drains? And some of them refused smallpox vaccines. But 4,000 San Franciscans formed an anti-mask league, and the mayor was fined $50 for flouting his own health department's mask order. I think we knew the $50 fine laws going. Anyway, slowly they got through to these people, but we have still got people like that. You know, plus ça change, plus ça remet, c'est la même chose. Next slide, please.
All right, let me just say a quick word about vaccines, because I know people are going to be interested in where we are with that. Next slide. So the whole principle of vaccine is you choose the antigen, the piece of the virus that is the key to producing immunity. And then you make a vaccine, and when you give it into people, it makes antibody, and it makes also what's called a cell-mediated immune response. Next slide. In this case, the RNA of the viral spike, that is the piece of the genome of the virus that encodes the spike protein, is the key target for virtually all of the vaccines that are being made. Next slide. The Moderna vaccine that you've heard about, it takes that particular RNA of the spike protein and puts it directly into cells. They do some little bit of manipulation. And remember that particular RNA can be translated directly, as you see on the cartoon on the right, into protein. So when it goes into the muscle cells, it starts to take over the ribosome and make spike protein. And that goes out on the surface of the cell and out into the blood, and it's seen by the immune system as foreign, and it makes antibodies. So that's how the antibodies are made. But it also can produce the same response as a cell-mediated immunity. So it produces both types of immunity. Next slide. This vaccine has been through primate studies. It's now into phase 3, and they've so far, out of the 30,000 volunteers, they have enrolled about 8,000, I think, as of a couple of days ago. They are having problems enrolling minority populations. Next slide. The Oxford vaccine, or AstraZeneca vaccine, uses what's called a vector. In this case, it's a chimpanzee adenovirus. They put the viral spike protein in that and put it into, it goes into cells, just it's injected. And in a similar way, it makes the protein, and it makes both antibodies as well as the cell-mediated immunity. So essentially, they both use the viral spike protein as the target for the immune system. And this one is also now in phase 3 trials, both in Europe, and it's just starting in the United States. Next slide. This shows you what's kind of the current situation. There are more than 170 vaccines that have been in preclinical. When you get to phase 1, there are about 15 vaccines. That's when you test for early tests for safety. And then phase 2, when you test to see how good the immune response is. You see the 2 vaccines that I just mentioned there are 2 vaccines currently in phase 2. And then there are, 7 vaccines around the world that are currently in phase 3 vaccines, phase 3 trials. You will know that the Soviet Union Russia supposedly has approved a vaccine that never even went past phase 2. So we'll see where that goes.
Yeah, yes.
Next slide.
Be careful of that one.
Yeah. Next slide.
So just to say, there are some strange stigmas around, just as there are resistance to masks. And so I will leave you with this slide. Next slide. Next slide. I think what we can do is very important.
Wearing masks, shelter in place where possible, social distancing. This has not changed. We are getting faster testing, as I mentioned earlier, and some other tools, but in fact, these principles without a vaccine remain essential.
I think that's the last slide. Next slide. Yes.
Okay.
Okay, we're done.
We have a few minutes for questions. Be happy to try to answer.
We've covered
Yes.
as much as we can, but it's complicated.
And we have a lot of questions for y'all. So the first one is, how accurate is the antibody test?
So the antibody test, it depends on what it's to. So the initial ones have been to the spike protein. But as more antibody tests are developed that look for immune responses to other parts of the virus, they will become more accurate. The antibody test is likely to be, its risk is probably going to be a false negative test. If it's positive, if you have antibody, it means you are very likely to be at least immune for a short period of time. But its accuracy is still unclear yet. We don't have enough information. New York has just done 1.5 million antibody tests throughout the city, and it's very instructive to look at the map and read it where that, we don't have time to talk about that, but they've learned a lot about how much infection was occurring in various parts of New York City.
And the bottom line is low income, crowded areas have the highest rates.
Right.
Great. So kind of related to testing, if you're positive in an antigen test, should the person test again for the PCR test, or is the antigen test good enough for case definition confirmation?
I would say that the antigen test, if it's positive, is generally means that you are infected. I don't think you need to go to a second test unless you. I would say if you have typical symptoms and your antigen test is negative, then you should probably get a PCR. But if it's positive, I don't think you need to get a PCR test.
Good. So the next question is from a school nurse, and she's concerned about treating students with asthma due to the aerosol that's involved. In the office, we do not have a good ventilation system. What is the best way to protect the room so others are not infected, including me?
I think if you can increase the ventilation, that helps. Wear masks, except where you obviously can't. One of the things you can do is purchase, and you do get these from Home Depot or Lowe's or wherever, small standalone HEPA filters, which recirculate the air within a room, pass them through a HEPA filter. I think that's about the best advice we can give at this stage, because that's a very knotty problem. So
it has been recommended to open windows, for example, under certain circumstances, but if it's 100 degrees outside, that probably isn't terribly practical.
Sorry. Don't use fans, because that's you're going to spread aerosol with fans.
So this is kind of a related question. Can you address ventilation recommendations for school settings? So they're particularly referring to the China restaurant slide and related to the question previously.
I think you need to look at the configuration of your spaces. What does the ventilation look like? Where is air being blown? Because your air conditioning system recirculates air. You're in quite a lot of trouble if you buy the vents. I think once again, space people, windows open if the weather permits. And I think once again, using these HEPA filters that you can place on the floor, a good idea. However, you need to be careful when you do that you have one that's adequate for the volume of the room. So you need to do a little bit of mathematics there and make sure you've got one that's big enough, or if you need 2 or 3. But nothing is going to be perfect. And everybody has to wear masks at all times. And you've got to stop the sort of crowding in the hallways, and you've got to stop the parties that we've seen. I think that I had people trying to do this have my sympathy. It's a difficult question.
Yes, it is. So one question is, you stated that the U.S. federal government has responded poorly. How so, and what might be a better way to respond maybe going forward?
Well, one can only look at what other countries did. They had a shutdown. We're talking about Italy, particularly in Spain, where they had a total shutdown of the communities with only absolutely essential movement, and they instituted masks quite early. But main thing is they really ramped up testing so that they could track the virus. And then once they got back in control of the virus, they continued ramping up testing, and particularly testing contacts to ensure that they could control and quarantine people who needed to be. And so for us, we saw a very nice response in Cameron County. We were down to 10 to 12 cases per day. That's a manageable number. That was during the shelter in place. But we were not in control. We didn't have enough testing to be able to manage it, and it was much too early to reopen the economy, and that just cost us not only more deaths, but a shutdown essentially of the economy. Because even if you open the economy and people are too terrified to go to do the things that generate economic activity, you haven't done anything. And so, as many have pointed out, it's the lack of control of the virus that has affected the economy more than anything. Yeah. And so early response back in February, March, a really early, strong response, availability of testing, use of masks, and the current things that we're doing would have made a huge difference in what we've seen. And that's proven in a number of different countries that did just that.
If you look back at some of those graphs that Joe is showing, you will see that all those countries that were successful had strong centralized responses. We do not have a centralized response, to put it politely. It's, you know, every state for itself and every man for itself. We have a lot of problems in our communities and our attitude to freedom to say, what about my rights? Without saying, well, what about my responsibilities? And unless we link those two things, it's going to be very difficult for us to get control of this virus. And as Joe said, the economy will not recover till we control the virus. So controlling the virus is essential to control, to benefit the economy.
Yeah, I like how you link those two. That's a good way to put it. So what are y'all's thoughts on the idea that herd immunity threshold may be as low as 30 to 40% when accounting for heterogeneity in the population?
Absolutely doesn't make any sense. This virus is at least as infectious as measles virus. We have lots of experience with measles virus, and measles virus requires about 70% or more herd immunity that's well studied, well established, in order to prevent transmission. This virus is going to, as Sue described earlier, if we want to get to there, we'll have 1.5 million deaths. And even then, it's not clear that would be enough to prevent transmission. So 30% doesn't make any sense.
And this is also a reflection that we need to make about the vaccination. We've got to have good vaccine uptake. If people refuse vaccine, we're never going to get control of the virus.
So we have time for about one more question. There's a lot more here that we might have to follow up on. But the other question is, if a vaccine is developed, would it conflict with the yearly flu shot? And should people still take their flu vaccine?
Absolutely. That's number one. Go and get it now. We try to get ours up before the end of August.
Yeah, the flu shots are available. Go get them now. If anything, it's hard to predict what's going to happen, but it's certainly conceivable people could get dual infections that would be very severe, particularly those who are already at risk. We have no idea, but certainly the two diseases will be confused with each other. And that's going to make it even more difficult to control the COVID.
And to treat.
And to treat it.
Treatment's different.
Yes. So it's absolutely essential that people get their flu vaccine. And there is no reason to think that the flu vaccine will interfere with the COVID vaccine when and if it comes, and vice versa.
They're entirely different vaccines.
Totally different viruses, different vaccines.
What worries me is that if you get flu and then you get COVID, you may be much, much sicker.
Absolutely, because flu does do injury to the lungs, especially in people at risk.
Or the other way around.
Or the other way around.
Yeah. You're injured with COVID, then you get the flu on top. That would be a lot more deaths.
Great. So just a follow up on that, is it possible to get a flu shot too early if you got it now versus October?
No, flu vaccine works. The flu vaccine makes a good immune response. The whole issue with flu vaccine is, did we get the right viruses? And that's a complicated question that we can.
That's a whole other story.
A whole other story, but we try our best. We, the royal we of the health system, tries to identify those viruses most likely to circulate, and that's the basis of the vaccine. But obviously, the vaccine has to come early. And sometimes you miss the boat a little bit in terms of getting the correct viruses. But the vaccine itself is very effective and gives it a very good immune response.
Well, thank you very much once again. We're at time now, so we will follow up. There's a few more questions, and hopefully we can get answers to those and distribute that to those of you on the webinar. So in closing, I'd like to really give a shout out and thanks to Drs. McCormick and Fisher-Hawk for sharing this information with us. It's so nice to get information from such renowned scientists and up to date. It's really hard with all the misinformation out there. So we really appreciate y'all's time.
Welcome.
Most welcome.
Great. We will be sending a link to the recording and the slides from this webinar out to everyone on this, so feel free to share that. You can also find more information as well as the first webinar we did on msdcenter.org. And then if you need CHESS credits, it's Dell Healthy Living at ph.tmc.edu. Thanks again for tuning in with us this afternoon, and y'all have a great day and stay safe. Thank you again. Bye-bye.